Thank you very much and for inviting me here. My presentation is not a study, it's a national-wide program, data that I'm going to share with you. And it was hard for me to select which I present and what not present here, because a national-wide program has a lot of information that can be shared in this forum. Quickly, for those who are not familiar with the locations of countries, Rwanda is a small red dot you see in the Africa. It's a small country, but with great people, and is highly densely population. HIV prevalence is 3%, but as I will show, we have other complexity of the epidemic behind this number. And one of the most important historical changes that happened, the life expectancy of people in Rwanda, that almost doubled in the last 20 years. And today we have 64 years of life expectancy. In terms of HIV, a quick historical overview from the first case that was described in Serashika with some of the colleagues I saw in the room, Francois and others. Since that time, a lot has been done, but as you know, in 1994, almost everything has been destroyed, and we had to start a new health system, building a new HIV program. So both had happened at the same time, rebuilding a national health system and also fighting HIV in an integrated way. And today we are happy that we've made some progress. The RT coverage has reached a level that we can say can move forward. New infections have been declined by half, and AIDS-related mortality as well. And the life expectancy of people living HIV in Rwanda is almost the same as the general population, as have been recently published. This has happened because of different strategies implemented, including treatment, combined preventions, and others. These are the estimates of new infections, trend over years, mortality from the model spectrum. And as I said, half of the new infections declined over the last 10 years, and AIDS-related deaths also declined by almost 80% in the last 10 years. Today, these are the most recent data we have from our AIDS indicator survey we conducted, almost done last year. The prevalence is still 3%. It has been the same for the last 10 years. But behind this 3%, there are populations with very high prevalence. Female sex workers, for example, they have the highest prevalence in the region, 51% are HIV infected. And the shift of the HIV prevalence peak at different age groups has also shifted. Recently, we've seen that it's going into the 50s and 40s years. Before it was more like 30 and 40. That is another change we have observed recently. Other groups have almost the same prevalence range from 2 to 4%, except the female sex workers, as I said. The main drivers of HIV transmission in Rwanda are these key populations: female sex workers, men who have sex with men, and discordant couples. They contribute greatly to the new infections. Discordant couples, through stable relationships, so all contribute 65%. And 20% from female sex workers, and from youth and MSM as well. So with this, our national strategic plan was looking at what can we do with limited resources, because we cannot target everything. So we worked into this focus on key populations with two goals: reduce new infections by 66% in the next 3 years, reduce AIDS-related deaths by half the same period. So what we have done was to tackle different approaches, but today I'm going to share this focus on guidelines. This looks a simple slide. It's not simple. But behind this is a lot of complexity. As program managers experience, who are here in the room, can testify how changing guidelines, implementing guidelines, evaluating the changes, and also restarting another change and make sure it's working, take a lot of time and resources. And this has been happening every 2 years, from CD4 count as cut-off baseline, 300, 200, 350, 500, Adding on that, other special groups, test and treat for co-infections, co-infected patients, under 5, female sex workers, MSM, and all that. This has been a challenge, and every 2 years we had to revise our guidelines. And today, the most recent guidelines we're implementing, we are treating with CD4 less than 500, and also with key populations, in addition to the WHO recommended guidelines 2013. And in the next few weeks, we'll discuss the test and treat approach in Rwanda, in Kigali. Behind this, the message we want to bring here, I brought from one of the health centers I visited a few weeks ago. I met a nurse A2 in a very far rural area, and we were doing a quarterly quality improvement and mentorship. Then she came to me and said, "Oh, you're telling us you bring another guideline. We are still working on the old one." They said, "Okay, but what are you doing?" I said, "You are confusing us. The time we want to make this happen, you bring a new recommendation." They say, "Yeah, but this is good for you." I say, "Why don't you make things simple for us and for you? Instead of saying these are CD4 and these are under 5, other groups, co-infections, other groups, female sex workers, MSM, serodisconnect couples." The list is confusing, and finally, we see that it's almost everyone. You're telling us, but you're telling us in a more complicated way. Why don't you simplify it? And for me, that was the main lesson I learned from the field that I want to share with you. Why don't we simplify our guidelines, make our lives easier, and treat people? Because the impact has been shown from this morning. And I'm going to share a few from the national data also, of the same message from that nurse in the rural health center. Integration of services is key, and we have seen that it's possible to make testing, PMTCT, and ART at all health centers. So almost all health centers in Rwanda have this full package, as this map shows. Treatment, we've been treating people, changing the coverage, and changing also the targets and guidelines. The 2 drops you see in the red marks are the time we changed from 200 to 350, the first one. And when we changed to 350 to 500, we also dropped the coverage. And the next, coming in August, we'll see how we drop again. But this is just to show that treatment can work and can make changes, as shown on this HIV cascade from Rwanda towards 1990s. Out of almost 210,000 people who are HIV infected, 86% ever tested for HIV. And for those who are tested, although we don't have the data here for those who are linked to care at a certain time, but we know that of those who are expected to start ART, we've had 500 CD4, almost 80% have initiated ART. And of those who are on ART, 86% have viral suppression at below 40 copies. Treatment and viral suppression is one, but what's the impact on the population in terms of reducing new infections? These are the recent analysis we did with colleagues, including Edward Mills and Julio, who is here today. So we want to see the effect of ART coverage on HIV prevention at national level in Rwanda. So we did this analysis, and we found that with 10% increase in coverage, we reduce new infection incidence by 6%. And this has been the same in all districts, all the 30 districts in Rwanda listed here. So this is to confirm that the ART work and can contribute to reduce new infections. To conclude, it's no more debate that ART changed the course of HIV on the field. The best way is to make it earlier, and the challenges we have shared with other countries include sustaining the gains with limited resources that include continue to decrease, retention of patients in care, and also manage resistance at long term is another challenge that we are facing and we will face, but also community involvement to understand the risk and benefits of diagnosis, immediate treatment, and maintaining people as long as they are on care, so that the impact can be seen on them, and the health of the people in the community are the tasks for us, and also the challenges ahead that we have to make happen. With this, I want to thank you for your attention, and also my colleagues who have helped to package this information.